rather than a series of debates, this is going to be more of a panel discussion, and obviously feel free to weigh in with questions or comments with everybody. So this was a 60-year-old patient, past history of seizures, poorly controlled diabetic, smokes a lot, so kind of the average patient in West Virginia. The BMI, I think, was under 50. Had a seizure, fell, had back pain, comes in, they're neurologically intact. L1 burst fracture. Here's the initial upright x-rays, the image on the right there. Not completely truly upright. We have a tilt table that radiology uses from time to time when patients are whining too much. But let's see. So we know our thoracolumbar stuff, right? So this patient, of course, comes out where they all do, right? They're neurologically intact. They got a burst fracture. Not sure about your PLC there, so they always end up as a 4, right? You can thank Alex for that. So this is kind of dealer's choice, right? So I think, yeah, there we go. So what do we want to do with these patients, right? These are our options. We've got all sorts of things we can do, and I'm just going to sort of throw this out to the panel. John, I don't know if you want to start and jump in, or you want to work we'll work the other way down. And also, guys, please remember to push the buttons on your mics. So, Ilyas.
Yeah, sure. So if we go back to the upright x-rays there, this is a really common thing that we see on call almost every day, maybe before, even the one before this. Just some of the patient factors or demographics. So when you look at the age, who was a patient like their 60s? If you just go back, maybe another slide here. Yeah, there we go.
60.
So yeah, patient in their 60s, significant past medical history there. Looks like of seizures, positive tobacco smoker, A1C of 10. Just looking at the scan there, they already look osteoporotic, fell during a seizure. So I think, looking at this patient neurologically intact, essentially we're looking at, looks like there's some anterior and middle column involvement there. So, you can classify it as a compression or sort of an incomplete burst, but probably more so on that axial loading mechanism injury here. I know there's a little bit, posteriorly, one might argue a little bit of splaying of the spinous processes, but I would argue that posterior ligamentous complex here is going to be intact. Just the fact that this is a low energy mechanism in an osteoporotic patient. Going from thoracolumbar junction, there's going to be a switch from lordosis into some kyphosis there anyways. And so this is a patient that I would, just screams in my mind non-operative. It's not anybody that I would want to touch surgically really at any point soon, I would say, or at all. Lots of room for optimization. This is a patient, you get medicine to see them, we'd have our smoking cessation team, bone health, and then kind of based on, it seems like they're coming in with back pain. So we found these patients, bracing is very reasonable in terms of kind of getting them up and mobilized, keeping them in extension. And so that's how I would start off here. But the bone health optimization is going to be really critical.
Great. Matt?
I'm on. Those are great comments. I think the operative comment there was anytime soon. I think I use this as totally agree. Everything about this screams non-operatively, both from a comorbidity standpoint and just a fracture morphology standpoint, especially the patient being neurologically intact. I would use this as an opportunity to talk about the two different pathways this can go down with the patient and really initiate some of this optimization processes. And that means, really getting that A1C down, getting a bone health evaluation if they haven't had one, and those kind of things. And I would talk about both both the surgical pathway and the non-operative pathway, but certainly start with the non-operative pathway.
I think we're all going to tend that way. We have to remember, like, did this really occur when they fell, or did this occur from the seizure? And the seizure itself's enough to do it. The seizure is actually higher energy. And so I might have a little worry. I don't know if this happened because of the seizure and the spasms of the seizure or the fall. And I agree there's maybe a little splaying of the spinous processes. So, and they're 60 years old. They're probably pretty osteoporotic from their smoking. I suspect just from that lifestyle, they're not very active, but also I wonder if they're on Dilantin or other seizure meds, and we need to address that. That might be why they have osteomalacia, perhaps. So I would address that. I'll probably MRI this one. I'd do a standing film. We get a lot of calls. As soon as these compression fractures turn into burst fractures, we get all these calls from ERs who are worried. You can't make a neurologically intact patient any neurologically better. Like, you can't impart superpowers by doing something. So if they're neuro intact, I might MRI this one. I don't MRI a lot of them unless I'm worried about cancer. But this one I might, because they're 60. And again, they look unhealthy. They probably look like an 80-year-old. But a 60-year-old, if this kyphos is severely over, it's going to be hard to fix down the road. So I might be thinking I might get a little more aggressive on this one, but I would probably MRI it to look at that ligamentous splaying and see if that was a disruption.
All right, so show of hands. Operative? Anybody? No takers. Non-op? Entire room? Confused? Not sure what to do? Okay. All right. So let's see. All right, so non-op 1 for now, till the patient was seen back in clinic, and usually this is kind of typical for us. People get a little bit lost to follow-up. If we're going to treat something like this non-operatively, for me, I'm going to see him back in a week. I think we all tend to keep a close eye on it if we're concerned, at least initially. But this patient now shows up in 3 weeks post-op. Worsening back pain, a little bit of EHL weakness. I think it measures 30-something degrees now at kyphosis at that level. So now we get the MRI, right? So there's a little bit of a deficit, and they're getting worse. So a little bit of impingement there. You could maybe make an argument there's some signal there. All right, what do you do at this point?
It's interesting, we didn't see that. That looks like that's through the spinous process. I wonder if we were, maybe scrolling through the CT, we could have seen it. It doesn't look like the supraspinous or ligamentous flavum is disrupted, so, that's splaying of the spinous process, but this may have been a kind of a bit of a B injury to begin with, which might be letting it kyphose further. If this patient's 80, I don't care if they kyphose 30 degrees. I'm not doing anything. I don't care how much they kyphose. I just let them go. But this 60-year-old, again, they may be physiologically 80, but they're 60, and this is not going to turn out well. Like, you're going to be seeing this patient. They already have a little ding to their conus, so I think you're going to have to deal with this operatively if they're starting to show neurological deficit. There's edema at the conus level. What's the bladder bowel function, Scott?
I think it was normal. I think the only deficit was at EHL.
Yeah, so I think if you're getting EHL weakness, in a 60-year-old, I'm probably going to do something here, because doing something in a year when it's really horrible looking is going to be really hard. So I'm probably going to deal with this now.
Yeah. Matt?
Agree. A major alignment change and a new neurologic deficit, and the combination of that MRI. And the patient won't be surprised, because we will have talked about this pathway at time 0.
Yeah, I agree with that. I think at some point, so there's a change of radiographic parameters, there's a neurologic deficit, which is a little bit, EHL. I mean, I want to make sure there's nothing else that we're missing down lower, but I think at this point it's still mobile. So when I look at the MRI and I look at the upright X-rays, so the last thing you want is essentially for him to heal in a really kyphotic posture. So I think doing an operation at this stage and potentially kind of locking him down, avoiding, would potentially avoid an osteotomy, a year from now. So.
This patient's also doomed by having like big, healthy, juicy discs on both sides, right? Like you've seen upper lumbar spines that have just like minimal disc spaces, but this just, it's more than just the bony morphology, right? It has so much motion ability once that posterior ligamentous complex is down.
Well, but the other good thing about that, to the contrary, is that a lot of times you get these and they're older and they're stenotic at all those lower levels, and you're afraid to stop above the stenotic segment. So one of the beauties is, to correct this, I think you're going to have to do something a little multi-level, but you could stop at L3 and you're nicely above a fairly healthy disc, and maybe it'll last a little while. It's hard to know. They may fracture literally above or below it within weeks. When you do, it's a problem, but at least you're not above a stenotic segment, which is good.
Yeah. So, Ilyas, pick a surgery. What are you going to do now?
So at this point, I mean, this guy, in my mind, he's still not going to be optimized. I mean, with his A1C as high as it was, and we don't have values for his bone, but just the way that it looked there. I'm thinking, what's the smallest operation that would essentially lock him down and prevent further, kyphosis down the road. To me, he's still, I know they talk, the EHL weakness, but to me, he's still for the most part neurologically intact. Dr. Nasser, one of my mentors at Mayo, he would say no one ever gets more than a 4 on an EHL, and he would just push everybody's EHL down on the ground and be like, it's never more than a 4. So there's a lot of subjectivity in the exam itself, but either way, I'd probably go 2 levels. I'd go posterior 2 levels up and down, and just try to lock him down there. I wouldn't do any decompression or anything like that here. He's a little bit tight. I think as the bone heals there, we have lots of evidence that shows with these burst fractures over time, even if there's a retropulsed fragment in the canal, that actually does resorb with time. I think as the fracture heals, it will resorb in the canal, and so I would just lock him down and end it there.
Cool. Matt? Procedure of choice.
Yeah, I'm going to say something I don't think a lot of people would say. I think a host that's got poor bone quality, and so osteoporosis is more than just bad bone quality, it's bad healing potential. And you add the diabetes to that, and I look at this as like something that's probably not going to heal well, and I want a very robust reconstruction. I think for me, the book answer, the board answer is that first answer almost for sure. I just worry that, allowing this thing is still hypermobile, allowing it to flex through screws, even if you augment the screws, which I probably would do if I was just doing posterior augmentation. I just worry that there's enough motion that those screws are just asking to fail, especially as this thing goes on to not heal. I do a fair amount of lateral. I do lateral corpectomies for tumors. I would not even hesitate. I would do a prone lateral. I would do a lateral corpectomy, and I'd perk 2 up and 2 down, and I'd cement augment the screws, because it's a minimally invasive operation. I can do it pretty quickly. There's no open incision, and it's incredibly robust.
Nice, John.
Yeah, I'm probably not going to go anterior on this. I don't want to really increase the height. Like if I have a young patient with a burst, I want to reestablish the height of the vertebrae. So I'm more inclined to use anterior support. This one, I'm probably going to let it shorten. My only worry with let it shorten, I just need to correct the kyphosis. I don't need to reestablish the height of the body, so I'm probably going to go 2 up, 2 down. I don't augment a lot of screws, but I would be prepared to augment these. What I would do is maximize my screw diameter in the pedicle and try to get some pedicle cortical purchase, because usually, you know, up at this level, I'm using 6 or 5 millimeter screws. I'm going to put 7s, try to really fill the pedicles with screws and try to make them click as they go in. Then I'm going to shorten them. The
Can I make
problem
one
with shortening
comment about
is-
what you just said? Because I think that's a super important point, and I think this is an under-talked about concept with navigation. I think if you have navigation up and running, you can literally trial your screw diameter and fill that entire pedicle, and that's incredibly useful in this situation. So,
Yeah, I think that's really the best tactic, even beyond when I can augment screws. I'm going to let this shorten and just try to correct the kyphosis. The problem with doing that, my biggest concern is what's going to happen with that fragment if I shorten it and correct it down. Am I going to jam it into the canal more? I know if this was 6 months down the road, I'm just going to do a shortening osteotomy. I'm going to take both pedicles off in the back, and I'm going to go in and just take that piece out and shorten it and shorten the whole thing. I don't even take the discs out. I just gain the same stability as Matt by shortening the spine, I think if you try to distract this open, you're going to not heal one if you don't put something in the front. So I'm going to probably shorten it. You know, with the deficit, I'm probably going to take off the pedicles and knock that piece out in the back and just shorten and almost make the discs touch each other. It'll just be a little wafer when I'm done. And then I'll end up with an aligned spine. You know, I think at this level, that's not that hard to do.
All right, so similar, yeah.
Sorry, just to clarify there. So, because I almost feel like by distracting with ligamentotaxis, like you'll almost get that, you'll flip that fragment back.
That's 100% what I would do in a young patient with good bone.
Yeah.
But I'm worried if I distract this, what it's going to do is going to create a cleft in it.
Sure.
It's not going to be like a young patient. And then I'm going to have this cleft that doesn't heal and fail. So I think if I opted to do that, because it will correct,
Yeah.
then I probably am going to feel obliged to put something up front to support that. And maybe that something's just cement. You know, I might put cement up front, but I think that's the problem here. But in a traumatic one, that's always what I'm going to
Because
do.
you may get pretty good correction just with positioning, you know, prone positioning here, but.
All right, so time to vote. So who wants posterior fusion, no decompression? Anybody? Okay. Come on. Lateral corpectomy and perc screws. All right. And who wants to basically just acutely shorten it and like all posterior?
yeah.
All right.
Can I ask you a favor? Could you back up to the 3-week, showed up in his brace x-ray? Is anybody underwhelmed by where that brace is? It's like basically the stiff segment is below the fracture.
Yeah,
Is that just a West Virginia style, or?
I think it's everywhere. It's the fulcrum style. It's the we need more RVUs, so I want this patient to fail. But yeah, it's amazing because, you know, I will give especially younger surgeons here some advice, which is when you go into practice, make sure you meet with your orthotics people too, and tell them what you expect, and make sure that they educate patients. A lot of times they running through the hospital, they're dropping off a brace and moving on to the next patient, kind of like, all right, here, put it on your back, it Velcros this way. Oh, you're in too much pain, I'm not going to roll you over. They don't a lot of times get them fitted even for it, and you know the patients don't know. So they just put it on. So, yeah.
So I would say this, I haven't braced a spine fracture of any kind in 20 years. It's useless. It does not prevent kyphosis. The data shows that strongly. It doesn't prevent pain. The data shows that. There's 2 randomized prospective studies that show that, as good as it gets. They're not huge, but I haven't braced one of these in years. The patients hate the brace. Years ago, when we were young, we used to do custom braces. We'd actually put them on an extension table, like a Risser table, reduce it, and make a custom brace. Some of them we didn't even cast, but we used to make a cast, cut it off. They would make the brace off the cast, and those braces had some effect, I think. The braces we use now, I would say they do 0. Every so often, if somebody's having pain, mobilize, and I'll offer them a brace to see if it'll help them mobilize, but don't kid yourself. The brace doesn't prevent kyphosis, and it doesn't statistically do anything for pain.
Yeah, John and Joe, you guys can see from the x-ray, you can probably tell who treated this patient initially. Okay, so, keep going backwards. All right, so what do we end up doing? All right, so this is one that I kind of inherited after the complication, but so I took it back. I did a laminectomy just to decompress the cord at that level and give it a little bit more space, and then just a posterior fusion, 2 above, 2 below, and with some pretty hefty cement augmentation of screws. So, all right.
Scott, let me ask you a question.
Yeah.
Do you ever employ like a uniaxial screw or a dual locking mechanism set cap to help avoid kyphosis with the distraction?
I used to use the monoaxial screw for a lot of my trauma stuff, and it just sort of it kind of went out of went by the wayside. I think I stopped doing it. I don't even think we can get them anymore. The ones that we had, which I liked the old dual USS for that, particularly thoracic spine. I like them.
For the younger people, like what he's alluding to is that the way a tulip head screw behaves when you distract or compress is very different than a fixed angled screw. So, I would play with that on a rod and see how that works. And that's why fixed angled screws, if you're trying to correct deformity or particularly focal kyphosis, are much more effective than a tulip head. The tulip head's easier to make all your connections, and I use a lot of tulip heads, but for all my fractures, I use fixed angled screws for that reason. This is why it's hard to correct fractures alignment percutaneously, because often we're using tulip heads to do it, and there are ways to overcome that, and there's different tricks to do it, but play with that because it's important to realize how they behave. They behave very differently.
Yeah, and again, in the setting of osteoporosis, I'm much less inclined to be trying to manipulate the body, so actively distract to try and get the ligament ataxis if we want to do that or anything like that. So that's pretty much the correction we got on the table, is what we went with. And again, it's kind of good enough is good enough in this case. All right, so with that, I think we are back pretty much on time. So thank you to the panel here.